Well, welcome in everybody. Fantastic to have all these lovely smiley faces here again in our longevity and health optimization group that we've got going. And today we have a very special guest, Dr. Melvin Nario, who is originally from the Philippines and now is in the States, and sort of he's across borders, and he's also across different types of medicine. He's an expert in everything from cholesterol, which is what we're going to be focusing in on today, and cardiovascular disease and comprehensive strategies for conquering high cholesterol. But I also know Dr. Melvin as being an expert in really cutting edge IV therapies, and as well as peptides, as well as hormones, as well as homeopathy. So he has an extensive knowledge base. So it's going to be an interesting Q&A session too, perhaps at the very end of this. But just welcome, Dr. Mario. Thank you so much for joining us today. And I will leave it over to you to do your presentation. And thank you so much ahead of time for sacrificing your time and putting this presentation together for our little group. Really appreciate it.
Well, thank you, Lisa, for that gracious introduction. So, well, let's start.
Yeah.
So, let's talk about a topic that is probably familiar to all, but let's put a little twist into it by adding a lot of evidence-based key points. Warning, though, you might hear information that might make you cringe. You'll find out in a bit. But remember, I'm just a messenger, and it doesn't mean I follow them. I'm just presenting the literature, so don't start throwing tomatoes at me. Maybe after, right? Here are my credentials. Before I start, I just wanted to thank Elisa again for this invitation. My mentors here in Reno, Dr. Cora, the late Dr. James Forsyth, who is part of our huge integrative cancer center here, Dr. Madge, Dr. Clearfield, who's also been here with us before, and of course my staff here in the office, especially Lucy. They wouldn't, I wouldn't function without them. And to our patients who keeps us believing every day in our skills, and who are actually are the unheralded everyday teachers. And most important of all, the one above, and why we are all here on this earth. As an initial conventional trained clinician, I was taught in medical school that the majority of approaches in lowering cholesterol are based on prescription meds. In regular medical conferences, they might even trump lifestyle, exercise, and diet. As I learned and experienced in the integrative world, prescription meds are not the only end-all, be-all of lipid therapy. To be honest with you, in my practice, I have never seen a huge amount of people who does not want to take statins, even if their life depended on it. For these patients who were educated, probably more than I was at the beginning of my practice, about the adverse effects of statins. Even if you offer or bribe them money or gold to take it, they wouldn't do it. This made me realize that I need to learn more about the other options, for I cannot let my patients go unattended with their cardiovascular issues. Thus, this presentation. Well, dyslipidemia is part of the top 5 risk factors as seen here in forming cardiovascular disease. Once lipids gets in contact with the endothelium, inflammation, oxidative stress, and immune dysfunction occurs, leading to cardiovascular insults such as plaque formation. These are common contributors to dyslipidemia, but the one that strikes me the most is chronic infection. Lipids can increase in relation to it being a protective mechanism to contain infection. I didn't know that initially. Nowadays, we talk about viruses, COVID. Can that make an impact? We will see in the future. But recently, when we thought that our fatty diet was causing all the issues, we probably have to think twice. Carbs are now considered the suspects in driving metabolic dysfunction. The National Cholesterol Education Program has brought up points. 50%, half of at-risk individuals are not identified with cardiovascular disease, and 50% of heart attack victims have normal cholesterol. That there's actually still a missing link in identifying cardiovascular disease when we thought we have the answers. Cholesterol here is not a menace because we always think of fatty food in relation to this. Here are the useful functions to highlight some of them. They are part of brain structure, mitochondrial function, hormones, our favorite vitamin D. Remember these in relation to the famous drugs called statins, because they are the ones getting affected. In its creation, you will see that the liver is on top of the list. Why we have fatty liver when overload of cholesterol occurs and cannot be disposed of. From here, let's start off discussing the greatest rivalries that the world has ever known. Great sports cars that became a movie, which is Ford versus Ferrari. The unending classic rivalry of Ali versus Frazier, going back to the slugfest in Thrilla in Manila. And who is the soda king of our era, Coke or Pepsi? But the greatest one of all, as far as I'm concerned, is which does not have any answer still. So who came first, the chicken or the egg? Even up to now, there's no answer for whom the winner is. We might never know. Kidding aside, to understand dyslipidemia, first, we must diagnose it. In our clinical practice, we see these tests a lot. The older classic lipid profile on the left and the newer NMR LipoProfile on the right. Thus, this is the rivalries in the diagnostic field of dyslipidemia. Which one should we use to assess our patient's cardiovascular risk to answer the cholesterol testing rivalry? Here are the versions of the two famous labs here in the US. And here's another version. Again, you would see here that, so you can get familiar with them, that the lipid panel and the NMR LipoProfile are two different blood tests that measures the levels of lipids in blood. The lipid panel measures the levels of total LDL and HDL, cholesterol, and triglycerides. The NMR LipoProfile measures the number and size of lipoprotein particles in the blood. It's represented by the dash P after the LDL word, as an example. The NMR LipoProfile test is more advanced than the lipid panel as it provides more detailed information about the number and size of lipoprotein particles in the blood. Information that can help us better assess a patient's risk for heart disease. So why should we use one over the other? There are multiple parts that we can discuss about how similar or different both panels are, but for the sake of discussion, let's pick the most common one that clinicians derive information from, and this is LDL. LDL-C from the regular lipid panel and LDL-P from the NMR. LDL-C represents the amount or mass of cholesterol carried by low-density lipoprotein. So the figure on the left, you will see, and it will be an easier way to understand this. And LDL-P measures the actual number of LDL particles floating in blood. So the multiple children on the right carrying cholesterol. As you can see, LDL-C is a representation of one, and LDL-P is a representation of many. In my own personal experience, the first that gets my attention in a lipid panel is the LDL. And I can already tell my patients a lot about the result by not even mentioning total cholesterol, HDL, or even triglycerides. So let's see which one is better to use in assessing CVD in an evidence-based perspective. So this might be the part where you'll throw tomatoes at me, but hear me out. This is just according to literature. We, as integrative docs, practice differently. First, let's talk about the positives of LDL-C. It does have evidence to guide us in predicting cardiovascular markers. Take note how regular lipid panel misleads us to think that we have done justice to our patients. When LDL-C less than 100, then we give our patients a pat on the back. This is where we evidence-based integrative docs come with our evidence-based literature to prove them wrong. In this slide, 60 is the magic number. Infants, monkeys, cavemen, they have no exposure yet to that much bad cholesterol sources, and that's why they are good baselines. Even 60 is the ideal number to reach when on statins. Anything above this number, as said here in literature, becomes a cardiovascular risk. How, and again, when you think 60 is scary low, here's 40 as evidence that we can limbo rock lower and still be safe. Start early to achieve this number, and that is actually a good target for the ones who are already plaque-ridden. And the false pat on the back scale that our labs guides us with, as indicated on the chart here, and talk about being misguided. More evidence here that when you have cardiovascular disease, multiple comorbidities, you should shoot for less than 40. Even on stent therapy, this 40 should be a goal. 80 is kind of like the higher ceiling as a cutoff. This is according to the Prove It and CARDS trials. Well, let's wake you up and get you jumping out of that chair. This is crazy. How low can we limbo? Don't we, I guess, have a limit in terms of can we still go lower and still be safe? Well, this is my reaction when I was seeing this evidence. Well, the buck stops here. At 30, hormone production will be the first one affected. Again, as the literature says, and not my clinical experience. I usually have higher numbers where I see symptoms already. I just showed you the clinical significance of LDL in assessing cardiovascular disease, or showed you the standards our conventional colleagues follow. As we scour the literature, we will now see a few kinks in the armor. In TNT and IDEAL trials, it shows how LDL-C is insignificant in relation to cardiovascular outcomes. And ApoB, which is another discussion overall, has a more reliable outcome, showing you here LDL-C's inaccuracies. Are we pointing our fingers in the wrong direction here? Triglycerides, VLDL, IDL-rich proteins, or other lipid particles are more atherogenic / dangerous than LDL. CVD pathology can still occur even with normal LDL. Even statins-treated patients at ideal levels of LDL-C still develop cardiovascular disease. The disconnect is due to the missing and not seeing atherogenic LDL particle numbers, which is the best measurement, again, of CHD risk. We are pointing our fingers at the wrong suspect when we use the wrong blood test. As you can see, the so-called bad cholesterol LDL is not so bad after all. It says that they are food even for our own cells. Good points about LDL. Lower LDL equals lower sources of inflammatory LDL. Once inflammation, oxidative stress, immune dysfunction acts on LDL, it turns it into modified LDL. Then the real problem starts. Lower the LDL says here, don't even worry about HDL according to this literature when you look at a lab, showing you that, again, by LDL alone, it can tell you a lot in terms of what the patient's status is. Is LDL the real enemy here? The real problem is inflammation. This is the reason why we say LDL is not our culprit, because the transformation of it is the real problem.
Sammy being out.
Here, evidence has shown that LDL-P is more accurate than LDL for driving CHD. Another evidence here that the lab standard that we use are not here, maybe in the US, are not as accurate according to this study. 700 is ideal. When we see it on top, it's less than 1,000, as they said. We also get introduced to the small but terrible small LDL, which is more destructive when there is high LDL particle, or P. And it's significant when LDL-P is low. It's like mini-me. It's like in the Austin Powers movie. The smallest particles are the small but terrible ones. This is because they have the ability to squeeze through tight junctions of the endothelium to start plaque in the intima. These concepts are also seen as evidence in the calcium score and carotid thickness, which correlates better with LDL particle levels, to show us that this is comparable to modern diagnostic scans and tests. Take note of LDL-P being the primary driver of CHD, why it should be the target of our therapies, and LDL is of no value. If we have established that LDL-P is a more accurate marker for CHD, then why, when we use statins, we use LDL-C to assess response to therapy according to many protocols? An example for that would be the American College of Cardiology. It obviously says here that statins won't move the LDL-P. Thus, we are looking at the wrong marker in assessing a major health problem. Once you see the icon clinical pearl, this means that I encounter these situations a lot in my practice and hopefully might make an impact in yours as well. This is a possible explanation for the false information that LDL can give when treating with statins. When they reach LDL normal goals, this could be the explanation that patient X that you saw yesterday, and you said, all is good since your LDL is normal and no upcoming heart attacks for you. Then you get a call next morning that he's in the ICU with an MI. Oopsies. This keeps our guards down as clinicians because we are not looking at the right parameter to treat. Missing LDL-P, which is more atherogenic, we are looking at the wrong test. Evidence that LDL-P is a better predictor than LDL-C for CHD. Even when LDL-C says normal, LDL-P is abnormal, consider LDL-P still due to its high predictability. Carotid thickness and calcium scores only correlates with LDL-P only, along with lipoprotein A and dysfunctional HDL. A head-to-head comparison is seen here that LDL-P can stand alone as a predicting factor for CVD. So forget about LDL-C, HDL-C, and triglycerides in the lipid panel. This concordance mismatch of LDL-P abnormality versus LDL-C that is normal misleads us clinicians to not intervene due to that falsehood of LDL. When you and you would see this correlation commonly in the high-risk patients, such as the metabolic syndromes, the insulin-resistant patients, obesity, type 2 diabetes, which we must probably intervene immediately, or sooner the better. Clinical outcome studies in cardiovascular disease clearly demonstrates that when all parameters of a lipid panel are showing you normal values and it's not correlating with the clinical presentation, you have doubts about its accuracy. So just follow the LDL-P that you won't go wrong tracking the CVD risk of your patient. LDL-P provides us help in understanding the CHD gap issue. It's defined as the persistence of CHD even when risk factors and labs are normal. Shocking news here, not only statins are ineffective, but majority of prescriptions in lowering LDL-P, are ineffective. Shocker that again, prescription medicines that conventional docs like to use are not doing anything for LDL-P. Then what are these medicines trying to do to our patients then? In the economical perspective, LDL-P assessments lowered medical costs for cardiovascular events. All more reason why our current medical system should adapt this. Sometimes I still get a letter from insurance companies saying that it is not covered for my patient due to it being still experimental. How can this be experimental when you see evidence-based medicine here backing this theory up? And now this is the real enemy, the transformation of LDL. That does damage to the blood vessels, damage associated molecular patterns or DAMPs, activating inflammatory receptors and stimulating immune system to fire up, specifically affecting the endothelium. Oxidized LDL is associated with the severity of cardiovascular disease. LDL cholesterol damaged by a chemical reaction from free radicals. Glycation of LDL occurs chiefly due to the non-enzymatic reaction of glucose and its metabolites with the free amino acid groups of lysine in which LDL is rich. So when you have a mixture of glyco-oxidized LDL, now you're really in trouble by combining both. As seen here, good old plain LDL just swims around until it gets into the endothelium where it gets modified, which is oxidized or glycosylated, and interacts with the macrophages to turn it into plaque. It's not that LDL that is the problem, but it's its modification. There are many reasons for LDL to be oxidized. Here is the list, but I just wanted to highlight how important LDL-P and size is in relation to this transformation, which can be seen in NMR LipoProfile, and usually when LDL-P is high and size is small, and that is basically a bad combo. Final verdict, the master list of rankings. Well, I don't see LDL-C on top here. Instead, it's LDL-P. It even is emphasizing to use LDL-P to determine CHD risk and assess efficacy of treatments. Since we're talking about testing panels, here's a clinical peril. I always hear from patients, don't worry about my LDL if it's high. It's all about the total cholesterol / HDL ratio, and I'm normal. It can still be used, but it doesn't trump NMR LipoProfile and LDL particle number. So correlation with the cardiovascular risk here. Remember the moments when we say to our cardiovascular patients, always maintain a high HDL, which is good cholesterol, and you will be okay. So high HDL, more than 85, are what we call stealth mutant HDLs. Good cholesterol gone bad due to higher atherogenic potential and also negative effects in terms of the beta cells of the pancreas to increase diabetes risk. This is where statins has been proven to lower dysfunctional HDL. Here's our two-faced enemy in the picture. As we can see, the target should just, as you can see, should just be in the sweet spot of 40 to 60 for HDL-C to lower cardiovascular risk, not over or under. 70 to 80, you're getting a little risque, and another favorite clinical pro of mine. Let's now discuss how do we treat dyslipidemia. Another bigger rivalry in our integrative field is our supplements, herbs versus prescriptions. Who will win this one? Usually the discussion will be favoring prescriptions due to conventional medicine leading the path in terms of studies. Let me show you first the initial treatment that is being considered by conventional medicine and its advantages and disadvantages. Our FDA approved list here, naturals has been recognized by the FDA as well on the list. Let's discuss the most famous one that we encounter in clinical practice and the one that we always want to replace. Statins, high evidence, again, as you can see here, effect on LDL and triglycerides. Out of all the prescription anti-lipids, statins are standing out in lipid-lowering effects in studies, and as well as its other effects in lowering inflammation and lowering down immune cardiovascular reactions. With all the good effects that statins brings to the table, there is a reason this faces a negative reputation in the integrative medicine world. Out of all the many that it affects, here are some special mentions. They deplete CoQ10 and Hem A, and thereby affecting ATP generation, mitochondrial electron transport chain, oxidative phosphorylation. It even inhibits the synthesis of vitamin K2, the cofactor of matrix GLA protein activation, which in turn protects arteries from calcification. Also inhibits the biosynthesis of selenium-containing proteins, one of which is glutathione peroxidase. And glutathione peroxidase, as a family of antioxidant enzymes. So this one, as you can see here, direct mitochondrial toxicity has, again, been seen on biopsy. And again, majority of these effects, side effects, as we call it, are from mitochondrial damage. As we always see in clinical practice, as muscle pain, brain, hepatic dysfunction, because these organs are full of mitochondria and they get destroyed. So the higher the dose you use, the more damage you get. And now this is why we're all here. And these are the natural therapies that can actually win this war or even be an ally to statins in terms of, again, the rivalries set against statins versus naturals. And this is now the evidence-based literature that supports how natural therapies do work. And these are the reasons why people like the naturals. The reasons can be classified as real beliefs of patients, such as possible adverse effects and even allergic responses. And the other reason are subjective beliefs, perceptions of adverse effects, and even personal preference. For this talk, we will focus on supplements and herbs in relation to our chosen therapies for dyslipidemia. So here, niacin, let's start with one of my favorites. In general, it is a fat buster of triglycerides and lowers fatty acids, prevents clot formation, and a potent anti-inflammatory and antioxidant. This study is showing how it is an HDL promoter, or good cholesterol promoter, but also affects the NMR LipoProfile and regular lipid panel in a good way. Here, this is I want to highlight the dose that I always use on patients. I start with a niacin ER, or extended release, at least 1,000 milligrams per day. You can go 500 even. Head-to-head was also done with fenofibrate, a prescription medicine, and they were comparable in the end in relation to the results, minus, of course, the common side effects of fenofibrate, which is GI upset. Has, again, had direct effects on the cardiovascular disease and CHD all over the board, lowers cardiovascular outcomes. This study shows that non-lipid lowering effects like being a good antioxidant, an anti-inflammatory, and anti-thrombotic of niacin in lowering cardiovascular events. We can go up to 4 grams and we will get cardiovascular effects, but it comes with a catch though. The higher you go, you get more side effects as highlighted. These are the most common ones, would be hyperglycemia and flushing, meaning supplements can still be dangerous if not used the right way. So I use a lot of niacin, especially for high lipoprotein A. My curiosity was by me driving to lower LP little a down, will I make my patients develop diabetes? Here's the answer. No, it increases diabetes, no increase in diabetes risk, but increases, of course, the slight hyperglycemia effect. 20 years of FATS-OS trial to show you that niacin is a team player. Here's a study combining it with statins, cholesterol, and of course niacin led to improve lipid profiles and even plaque characteristics on carotids. Using it for 2 years at 1 gram per day was needed to lower carotid thickness, evidence that supplements work, but it takes time, and sometimes a lot of time, even a longer period of time. Here's a tag team study of niacin with statins and ezetimibe versus ezetimibe on how it helps with carotid thickness. The combo therapy of niacin, statins, simvastatins, or bile acid resins, here cholesterol was used, is also improving andrographic findings. The famous side effect of flushing is explained by the stimulation of the dermal Langerhans cells by prostaglandin D2, leading to vasodilation. If this bothers you, laropepran is the solution, but unfortunately, it's no longer sold here in the US due to it being pulled out from the market, for it shows that it increases gastrointestinal bleeding. Yeah, I'll take the flushing instead. And how to prevent the flushing? Here are some tips. Titrate slow. Take with food. I like to recommend apples with it. Use quercetin or aspirin 81 milligrams along with it. No alcohol, so don't be drinking alcohol with it. And no interruptions of therapy, and be consistent. And a special mention, not related to flush prevention, but closavalam takers, it lowers the hyperglycemia effect of niacin and has a synergistic effect with niacin to lower LDL. Red yeast rice monocholine, as you can see here, is the active ingredient, and this inhibits cholesterol synthesis via HMB-CoA reductase, usually known to be the natural statin. Notice here that even at low dose, it lowers LDL by 22%. 2,400 milligrams at night dosing, same effect on LDL, but other additional effects on other lipid panel parameters. Take at night when cholesterol formation is more prominent. Even in most MI and overall cardiovascular disease, it lowers mortality. Not only does it affect lipid panels, but also other inflammatory markers such as MMP9, hsCRP, increases nitric oxide, and even lowers the size of your aortic aneurysms. It also is suggested to be an alternative choice for patients who has myopathy with statins. A multi-center randomized placebo-controlled study in US and China, the effects are related to dose. The higher it is, of course, is the more beneficial. The team player effect also seen here with red yeast rice, along with niacin, phytosterols, L-carnitine, vitamin C, CoQ10, as they improve lipid panels. When we hear statin-like, we also think about the same possible side effects of a statin. But here it's a rare occurrence, especially myopathies, hepatic dysfunctions, or diabetes. Reason why this is a famous choice as an alternative therapy. Intolerant patients, it can still produce some myalgia, so be careful. Dose dependent, but less than statins. Again, statin-like, we know statins are strong CYP enzyme inhibitors. Red yeast rice is strongly inhibiting this, like statins, in relation to drug interactions, though not as comparable. Our patients likes to buy cheaper over-the-counter supplements. This one you don't want to play with. Some red yeast rice products may contain a toxic contaminant called citrinin, which can damage the kidneys. Citrinin can form during the fermentation process if it is not carefully controlled. In a 2021 analysis of 37 red yeast rice products, only one had citrinin levels below the maximum level set by the European Union. Only, again, get from trusted sources. Here, omegas acts as, of course, the regulation of hepatic and intestinal HMG-CoA reductase. One of the most studied supplement that reduces CVD, CHD-MI, CVA in numerous trials seen positive effects in post-MI, lowering mortality and preventing cabbage occlusions. Striking to me is 45% decreased sudden death, almost 50. Will you not take that?
Wow.
Recommended dose can reach up to 4 grams. How powerful and dynamic it is. Shown here, all atherogenic particles are down. Anti-inflammatory. Why we use it also in pain, antithrombotic, assisting clot conditions, even improving heart rate variability, improving PNS activity. It can even relax you. Increases eNOS or nitric oxide, helps with the circulation. Why it's one of my favorite cholesterol supplements. I mean, omega fish oil can relax you. That was astounding to me when I found that out. And again, let's address that big elephant in the room. Can it cause AFib? There are risks only present in, especially with the ones with cardiovascular comorbidities. For healthy users, very low of an evidence. So there may be a dose-related risk of AFib with omega-3 fatty acid intake. Dose-dependent effects go low and slow, as I suggest on how to use this. 4 grams a day, probably that's going to be the highly statistically significant dose that you might affiliate AFib with. So we should inform our patients about this risk. When we use these high doses, I usually don't go over 3 with my patients. And again, majority of these occurrences will be happening with the ones that has comorbid conditions. In the JELIS trial here, as you can see in the team player slide, and it was done in Japan, omegas plus statins reach cardiovascular goals faster than the statins alone. In omegas, they contain long-chain omega-3 fatty acids called EPA versus DHA. That's pantenoic acid and docosahexaenoic acid. That's why I don't pronounce those long names. Why we call them EPA, DHA, because it's hard to pronounce. Which one carries the more importance? Seems like DHA carries more effect in lowering inflammation and affecting lipid numbers. So systematic review and meta-analysis of randomized controlled trials here is the basis of my answer to this common question that I get from my patient. Doc, is krill effective? Should I use that? Well, krill oil comes from the tiny shrimp, like marine animals. It's rich in omega-3 fatty acids, EPA, DHA. Krill is also effective, but I still prefer omegas from fish due to it being less expensive, though the controversy of, sources, mercury, right? Of course, get it from smaller fish like anchovies, and also having more non-lipid lowering benefits like anti-inflammation. Literature is not as heavy as omega fish oil versus krill oil. So not only can we get lipid lowering effects from supplements, but here are power food sources as well that will help. We always think we are lacking in protein in our diet. Why we focus more on animal meat intake? The one that is really deficient in our diet is fiber. Why there are a lot of people constipated? Because of this. To differentiate fibers, soluble fiber attracts water and turns to gel during digestion. Insoluble does not dissolve in water and typically remains whole as it passes through. Studies back soluble fibers more than in terms of improving lipid panels versus the insoluble ones. The MUFAs, as we call them, are monounsaturated fatty acids, improves lipid panel and cardiovascular mortality. Can be seen usually in the famous Mediterranean diet. And it's also called the heart-healthy diet. Not only does it affect lipid panels, but also lowers glucose panels, anti-inflammatory, and even getting involved in gene translation to prevent CHD. How powerful is that? It goes into your genetics. I always suggest use extra virgin olive oil. Extra virgin olive oil is cold pressed and left unrefined, while regular olive oil is heated to extract the oil and is refined. You see, again, the team player icon here works well with omegas for lipids and free radical control. You need 20 to 25 mils per day to get the benefits. So be creative in chugging it down, mix it with a salad or food choices, or dip healthy bread to it. Whatever is acceptable, just get in it. Meaning whatever you prefer to do, just put it in your body. Here, garlic is not only an anti-Dracula remedy, but it's also an anti-cholesterol remedy. It also inhibits HMG-CoA reductase. It also lowers blood pressure and decreases cholesterol absorption. It also lowers calcium scores and plaque, of course, in synergy with statins. Meta-analysis here to reap the benefits of the cardiovascular effects of garlic use aged Kyolic garlic, as seen here in lipid panel, 600 milligrams twice a day, recommended use for the, I guess, and you use the cardiovascular formulation of this, because there are different types of aged Kyolic out there. As I see patients, I get a lot of questions about these food groups in relation to dyslipidemia. Are eggs a problem for cardiovascular health? Unfortunately, the only one affected by this are the diabetics. They are even worse than the ApoE4 genotypes, according to the study. 1 egg a day is okay for the general population. Again, don't throw tomatoes at me. This is just a study that I'm citing. It could be different for everyone. Another question is dairy healthy? It's a double-edged sword. In general, for dairy, since it can increase CHD risk, but reduces diabetes risk. Overall, only fermented dairy are protective. Cheese and yogurt. The other types like skim are no-go. Lastly, is coconut oil healthy? Unfortunately, it can increase total cholesterol, LDL, triglycerides, but silver lining is it increases your HDL. In summary, dyslipidemia is still a major risk factor for CVD. When we thought we got it all figured out, we still don't have the solution for dyslipidemia for all these years. You will see that because CVD is still the #1 killer in the US. Thus, we need to be aggressive in our approaches. And of course, NMR LipoProfile, by using the right testing method, we will be guided more accurately on how to assess and treat our patients' cardiovascular problems. And statins do have a place in the medical world, as evidenced by the literature. In the integrative world, it has a bad rep. Let it be our ally and not our enemy in the fight against dyslipidemia. We just have to use it wisely and understand it better. And natural therapies are effective. It may be, again, slower than statins. We just need to know when to use them properly and wisely, may it be in combination or by itself. And lastly, nothing beats prevention. By focusing on 3 pillars of cardiovascular disease prevention: less stress, more greens than meat, and bodies in motion, we will develop the best foundation to fight heart disease. And peptide stack that I consider for my high cholesterol patients. So TA1, reason for that is, of course, it suppresses pro-inflammatory cytokines like interleukin-1, TNF-alpha, which is a driver of atherosclerosis and myocardial damage. And also, there's another one here is called BPC-157. It stimulates your vascular endothelial growth factor and nitric oxide production, thus promoting new blood vessels, forming, to bypass blockages and restore blood flow to damaged tissues. And here's the new baby in the block. Not new, really, but it's something that's very helpful, and I've seen it in clinical practice, the reduction in major, adverse cardiovascular events and improved endothelial function that it brings to the table. It even lowers systolic blood pressure by 2 to 6 millimeter mercury, and modest reductions in total cholesterol, LDL cholesterol, and triglycerides can be seen. And some GLP-1 receptor agonists have shown positive effects also in kidney protection. So questions, comments, and feedback, and yes, even complaints, please contact me with all my heart and gratitude. I want to thank all of you for taking time learning from my lecture, and hopefully I have given the gift of education to you in helping your patients achieve better health. Thank you for your time, and God bless.